Hello again. I would like to present my experience in the Persian Premium from Multifocal IOL in 2018. Patients who undergoing a premium IOLs implantation tend to have higher expectation about the metropia than monofocal IOLs patients. It's simple to understand that cataract patients are almost always easier to please than refractive lens exchange surgery patients. Deciding on the right IOLs for a patient is critical in successful implantation. We should identify the visual need of the patients and recommend a type of IOL based upon this requirement. Beyond a correct biometry, optimal pupil diameters, intraoperative devices for the correct alignment of toric IOLs, or even metropia as a result, we should consider some other parameters for the most appropriate choice of a premium IOL and the appropriate patients for them. We should get accustomed before indicating a multifocal IOLs to know how multifocal the cornea is. Well, for center that working with Pentacam on the distribution of total corneal refractive power in actual zone map, you can have this information. It is the typical histogram of a monofocal cornea with a repeating keratometry value and a base no wider than 1 to 2.5 diopters. The most multifocal a cornea is, the less indicated multifocal IOL. If the base of the pyramid is wider than 4 diopters, ocular surface. So every premium cataract patient in our practice is first evaluated for ocular surface disease and treated with the same aggressive protocol we use for our LASIK procedure. In my clinic, we work with two platforms, with the keratograph and with the software of surface of bicassic. In the clinical evaluation, you always want to pay careful care to the retinal OCT. Sometimes you're going to have a surprise back that may be why the patient isn't seeing well beyond the crystalline. In my opinion, it is very, very important to achieve a postoperative emmetropic outcome, which at times requires a laser vision enhancement. Premium IOL don't always eliminate the need for glasses. We must have a plan B. If you work with multifocal or toric IOLs, you need to have always a plan B for solution small refractive error. Most patients are very well with premium IOL and don't require enhancement surgery. For patients who have residual refractive errors, after premium IOLs implantation surgery, the IOLs can be repositioned, exchanged, or a piggyback lens can be implanted. Even femtoastigmatic keratotomy may be appropriate. But in our experience, in my clinic, LASIK is in general considered as the refractive procedure more performed worldwide. PRK can also be a good option in some corneas. We should discourage multifocal lenses in abnormal or aberrated corneas. Detection of incipient stage of corneal irregularity will help us to be more careful in the calculation of premium IOL, especially in the analysis of the back elevation and keratometric power deviation of the cornea. The majority of patients who come our clinic by femtolasic or PRK after premium IOL implantation have topography and the rest of the corneal preoperative study normal, being therefore good candidate for this procedure. Femtolasic and PRK have shown in our hands to be a viable, non-invasive and accurate procedure to correct low or moderate ametropia after refractive lens exchange with implantation of premium IOLs. But if you want to introduce a multifocal IOL inside every eye, you need to have a plan B for maybe use the cornea for the solution with laser, femtolasic or PRK. And thank you for your attention.